So just want to start off with our land acknowledgement. Northreach Society Grand Prairie and our sister agency in Fort McMurray acknowledges that we are located within the boundaries of Treaty 8 lands. Northreach Grand Prairie and Fort McMurray is grateful to the Beaver, Cree, Dene, and Métis peoples for allowing us to work, live, and grow on these beautiful lands. Indigenous peoples of this region have existed here for over 15,000 years. We are thankful for the elders who have gone before us and their care and stewardship of these lands since time immemorial. So today's presenters is Dallas Sather. She's our overdose prevention nurse. Audrey Mickelson, women's health outreach worker, and myself, Ebony Loops, and I am in the Indigenous Opioid Response Coordinator position.
So good morning, everyone. My name is Dallas, and I am the RN here at Northreach. One of my primary roles is to teach naloxone and to help people respond to overdoses. The other pieces of my job are a little bit more off book, but in scope still. I support our other projects here at Northreach with nursing, advocacy, and all the things that come along with that.
So with the Indigenous Opioid Response Program, we create a holistic community-centered harm reduction approach for Indigenous peoples and communities, culturally safe overdose prevention programming, including naloxone training. We address stigma and discrimination associated with these substance uses and increase culturally safe practices and supports for individuals using substances, leading to an increase in health and well-being. Also, increased knowledge and understanding of why a holistic Indigenous trauma-informed approach is necessary, and ongoing community discussions about culture and its role, prevention, intervention of substance use disorders.
And I am Audrey. I am with the Women's Health Outreach Team. And the WHO program, we approach our work with a harm reduction approach, and we support a variety of women and children. Some of the things that we do is help with securing ID and Alberta healthcare. We can assist with income support, prenatal healthcare. So that's connecting women with physicians or nurse practitioners in the area. We can help organize STI testing and support with treatment options, as well as birth control. So for women who might not have benefits, we can help with that. Prenatal vitamins and lots of referrals to external community supports.
This presentation will cover an overview of what exactly harm reduction is. We're going to review stigma around naloxone and opioid consumption, facts and statistics regarding naloxone and the opioid crisis here in Alberta. Again, how to use naloxone and signs and symptoms of an opioid overdose and how to respond, how and where to get a kit, safe needle pickup instruction, and we'll go through that, how to support individuals at risk, and the importance of sexually transmitted infection testing and where to get tested.
Okay, so we're just going to probably turn off our cameras now and focus on the slideshow, and then we'll come back on for the Q&A after.
Harm reduction. Harm reduction is a public health philosophy that reaches people where they're at. The goal is to reduce the negative consequences of a behavior, and it may result in the eventual reduction of the behavior itself. Any positive change is considered a form of harm reduction. In harm reduction itself, it requires openness, honesty, and a non-judgmental attitude. Some examples of harm reduction are seatbelts, condoms, and other safer sex supplies, and safer drug consumption supplies. This is a really good PowerPoint slide. I don't promote drug use. I don't promote car accidents either, but it's still a good idea to use seatbelts. What is stigma? Stigma is a marked disgrace associated with a particular circumstance, quality, or person. Synonyms, I can't say this word, for stigma are shame, disgrace, dishonor, and humiliation. Is there stigma around naloxone kits? Absolutely. There is, and it's no different than carrying a first aid kit. And why is that attached? We need to talk about that. And is there stigma around opioid use? Absolutely there is.
So some of the things that we at Northreach, we do a lot of education and training about the importance of addressing stigma. And so a couple of points here. So stigma and discrimination towards people who use substances and or have mental health concerns is a widespread public health concern. And the reason we say that is because stigma can impact individuals who are seeking help. They're seeking, whether that's in the form of drug and alcohol treatment or mental health treatment, or even just seeking regular health care, right? So it's important to remember too that service providers or healthcare professionals are no less susceptible to stigmatizing beliefs than members of the general public. And that's not to try to devalue or to discredit people in any way, shape, or form. It's just that recognition that, we all carry beliefs. They've all come from somewhere, whether that's just the environment that we grew up in, or sometimes, people are directly taught things that that maybe don't serve us anymore, right? So stigma and discrimination, it can prevent clients and patients and families from seeking professional care for substance use or mental health concerns. Clients and patients often report that stigma associated with their substance use or mental health concern is more difficult to bear than the actual disorder itself. And for those of us who have worked in that outreach capacity, supporting individuals, whether that's going to the emergency room or trying to get admission to detox, wherever it is, we've seen it firsthand, and it definitely can be distressing for a lot of the individuals that we support. And the things that we often also talk about when we're addressing stigma is that intersecting of ways that people are stigmatized. So for instance, we work a lot with individuals who use substances, so that's one way that people are stigmatized. So we think about, the intersectionality of those social identities that people have. And so for instance, the example I always use is if we have an Indigenous person who's also a woman, who's also a substance user, who also might have mental health concerns, and maybe they also use substances intravenously. Now we have 5 ways that somebody is facing stigma. So you can imagine for an individual who that has been their experiences repeatedly throughout their life, or even parts of their life, it can be very difficult to deal with that type of thing. So that's why we feel it's important to address stigma.
So language directly impacts how we view and treat others. So it's really important that we not define people by their illness or circumstances, and this recognizes the person as a human first. So the example I actually like to use here is quite personal. Our youngest daughter, her name is Tor, and she has autism. So what comes to mind sometimes when we think of autism is a lot of stigmatized thought, right? And so if you hear about the autistic kid, sometimes we think about Rain Man, we think about people losing control and self-harming and screaming and not having any language. So if we refer to Torin as being autistic, a lot of stigmatized thoughts and stereotypes can come to mind about who she is and how she might represent in the world. When in fact, she's actually quite brilliant with excellent language and has developed empathy with health. And so she is torn. She's this lovely, beautiful little 8-year-old who happens to have autism. So the reason I use this as an example is because the difference between saying somebody is experiencing or suffering from autism versus saying she's autistic. One is a characteristic, the other is a definer. So my suggestion is a tiny little way to change your language and to kind of change the way you might be possibly using language in a stigmatizing way is to actually remove the ick from your language. So if you say autism instead of autistic, if you say someone with schizophrenia instead of schizophrenic, don't use alcoholic, use somebody suffering with this alcohol use disorder. So if we just take the ick out of our language, we actually will stop labeling. So that's just a little tiny way you can redirect yourself today and going forward.
This is just highlighting ways people commonly in different environments address, label people. And this is a better use. Often we say addict, junkie, druggie. Lots of this has to do with the environments we're in, like Audrey was saying. And I think it's our responsibility to, as people, to change that language, to change those stigmatizing use of language, change it to a person with a substance use disorder, a person living in recovery instead of saying an ex-addict, a person living with an addiction instead of, battling, suffering from addiction. These are really important and a good reminder of how to say it better.
Yeah, and I just want to quickly direct you down to actually the bottom two statements. The one is stayed clean and the other is dirty drug screen. So these are two fairly common things that I would have used that I do and have used as an RN working in various parts of the system. There's nothing intrinsically wrong with the labels, and they were words that I used often. And then I had the opportunity to work with a nurse practitioner who actually helps people try to maintain sobriety. And the one thing she asked me is to never use these two labels. She said, asking somebody how clean they are or how long they've been clean is not the issue. She said the opposite of clean is the issue, and nobody's dirty. And I just thought that impacted me so much, again, with my language and perception. So the clean isn't the issue. It's implying that if you aren't sober, that somehow you're dirty. Same with the dirty drug screen. The reason I just want to highlight that is because it is the only lab sample, anything we take that we would ever refer to as dirty. We don't say a dirty pregnancy test. We don't say a dirty urinary tract infection test. We say it's positive for whatever. So it's, again, just changing that language and trying to get away from these dirty implications. Okay, so now we're just going to move into talking about the opioid crisis, talking about naloxone and how to respond. So we're kind of getting into the meat of things here. So now that we understand that most of us have some sort of stigmatizing thoughts or behaviors, we can move into now learning about the opioid crisis and maybe changing some of the ways we may think or perceive the crisis to be. So these are just a few stats that have been collected over the years about the crisis in Canada and in Alberta to just kind of give you a demonstration of how significant the impact is as far as opioids go in this country and in our province. The one I'm just going to discuss here is actually Canada's number 2 in the world per capita for prescription opioid use. And why do you think that is? When we think about how in North America we perceive pain, pain is something we're just not supposed to endure. So nurses and physicians for a very long time were told that we need to treat pain, that pain is so important that people should not experience it. So what happened before there was a real awareness of how addictive opioids were, they were prescribed a lot to help with pain. So that a lot of the source of the dependencies in our country, certainly, and in North America, is due to this desire to actually help people not experience pain. So with the addiction, then often starting from prescriptions, then it can move into more of an illicit dependency as those prescriptions dry up. So just to give some context there. Okay, so this is where it's happening provincially. As you can see, we've got some fairly disturbing numbers as far as when we kind of looking back as far as 2016. Okay, so I'll just direct you to this year. As of the first 3 months of this year, we've had 142 people pass away in this province from some sort of opioid overdose, whether it was mixed with another substance, whether it had fentanyl in it, a different kind of opioid, or was cross-contaminated in something like cocaine or crystal meth. So we're still sitting at about 1.6 persons per day passing away in Alberta from an opioid poisoning. So that is still a high number. However, it has decreased over the past couple of years. Last year, we averaged about 200 people dying per quarter in Alberta from opioid poisonings. And so far, for 2019, it was about 150 per quarter. So that is quite a decrease, but it's still way too high. So just to kind of focus us more into the North Zone here, in 2018, we had 43 people pass away from fentanyl-related poisonings in the North Zone. And in 2019, as you can see, we had a little bit of a surge at the beginning of the year with a decrease towards the end of the year. So for the first quarter of this year, we've had 7 accidental poisoning deaths due to opioids, with 3 of these being right here in the city of Grand Prairie. This reference is from the Alberta Opioid Response Surveillance Report, which is available readily online to anybody that wants to look at it. And it's quite interesting because it can give you a lot of information as far as rates and prevalence, where EMS is stressed, where emergency rooms are stressed due to the opioid epidemic. So opioids and then the naloxone reversal effects. So many of us know what an opioid is, but they might not necessarily know some of the kind of more medical terms for it. So opioids is a morphine-like synthetic narcotic, and it's derived from the opium poppy. So it's a very old drug, right? It's been used for a very long time. Examples of these, both licit and illicit, are things like heroin, morphine, oxycodone, hydromorph. These are drugs we give in the hospital. Methadone, Demerol, codeine, fentanyl, and of course carfentanil, which really permeated the drug supply a few years ago. It's an elephant tranquilizer, and it caused almost certain death to people that ingested it or used it. So this is just an idea to give you an idea of the strength difference between carfentanil, fentanyl, and heroin. As you can see, there's quite a bit of heroin in the vial compared to the fentanyl, which is literally grains, and the carfentanil, which you basically cannot see. So it's just giving you a demonstration of the strength and how dangerous these drugs are because of how toxic such small amounts can be. So when somebody ingests an opioid, what happens is that the opioid is attracted to the receptors in the brain that actually help us to feel pain. So if I have a knee injury and I'm in a lot of pain, and I take a Percocet to help stop that pain, it doesn't actually stop the pain, right? It just stops my brain receiving the message from my knee that I'm in pain. So inadequate or improper doses, what will happen is I won't feel the pain, I'll experience more comfort. If I take too many Percocet, what happens is that those same receptors in the brain are actually the receptors in the brain that drive our body to breathe, that tell us to take a breath. So those receptors, if they get too many opioids on them, there's a cessation of breathing. That's what it does. It doesn't stop our hearts. It doesn't generally cause effects on other systems initially. It's on the breathing. But when we stop breathing, eventually our hearts stop and then we pass away. So what we're seeing here in this visual is the opioid attaching onto the receptors in the brain, and then this body will stop taking breaths because the receptors are all blocked. So then we come along with this amazing drug. It's called naloxone. It's an opioid antagonist and it blocks opioid receptors. So what that means is that I'll show in the next picture how it works, but it actually causes the receptor in the brain to not be able to take the opioid on because it's stronger. So it helps reverse fatal unintentional opioid poisonings. So the reason we're saying unintentional opioid poisonings is because the vast majority of people, when they are consuming opioids, are not doing it to end their lives or to stop breathing. They're doing it to either numb emotional or physical pain, or to prevent themselves from experiencing withdrawal, which is extremely uncomfortable. It's very, very painful and terrible when you withdraw off an opioid. So generally speaking, when people are using, they aren't planning. The plan is not in any way suicide. So we say unintentional because they truly are. Okay. It should be stored between 15 and 30 Celsius and protected from light. So often we keep our kits in our vehicles. That's a natural thing a lot of people do because you want your kit where you're going. In our summers, our vehicles can easily get over 30 Celsius inside and certainly below 15 Celsius in the winter or spring or fall. So that being said, if you do forget your kit in your car, it does get too warm or it does get too cold, and you come along an overdose, by all means, do not think you can't use your kit. The research shows that it will still work, even if it's not kept in the optimal temperature. Ideally, keep it in your work bag or your backpack or somewhere where it can go in and outside. But if it does get forgotten in your vehicle, please still use it. Okay, naloxone is a key component in overdose prevention. So this is a picture of how naloxone works, what I was just talking to you about. So naloxone has a bit of a different shape, and it's bigger than an opioid in the brain. And so it just will actually kick the naloxone, or the naloxone will actually kick the opioid off of the receptors in the brain, and then the person will get the drive to breathe. And for those of us that have seen it, it really feels like a miracle. It really feels like magic. I cannot tell you enough that when that naloxone gets in the system and starts to circulate, it does work, and people just take these epic breaths and have the chance to see another day and hopefully find healing in the future. So this is what an overdose looks like. We're looking basically at body systems. So it's kind of a basic first responder. So when I say that, I mean, if you've taken first aid, CPR, you look for the same things in an overdose that you would if you were looking to see if somebody had a heart attack or drowning. So airway, breathing. Is there an absence of respirations? Is the person breathing or not? Okay. With this, they can sometimes be making groaning noises, or there can be some gurgling with an overdose because the secretions start to gather really quickly. But if you look at their chest and their chest isn't moving and you can't see breathing, that's an absence of adequate rest. Okay. Heart rate can be slow, erratic, or not there at all. Again, as we have less oxygen in our body, that's what will happen. Skin color, this is a fairly key one. So the fingernails and lips can turn blue or purplish black. The skin can be pale and clammy. In really dark skinned people, if you can't tell, if you pull down their lip, the inside of their lip will also be dusky. They will not be able to respond to you verbally. Response to pain, so they don't respond to pain. So someone's not breathing, and you determine this, you can do a sternal rub or somehow induce some pain to see if they respond to pain. A lack of response to pain is a way to also assume that they are in some sort of poisoning event. Muscles, there's very poor muscle tone in their limp, and the pupils will be pinpoint usually. But any one of these isn't necessarily enough, right? Just because I have pinpoint pupils doesn't mean that you assume that I'm having an opioid poisoning. You're really looking for a lack of response to pain and a lack of breathing. So this is what's inside a naloxone kit. So any of you that want kits can let us know via email, and we'll either have them ready for you to pick up somewhere or possibly mail or deliver them to you, depending where they are. So we have 3 syringes in the kits, 3 doses of naloxone, a pair of gloves, 3 alcohol swabs, and a rescue breather. The reason there are 3 syringes and 3 doses of naloxone is actually because it could take more and often does take more than 1 dose to reverse an opioid poisoning. So you need to have more than 1 dose in your kit just in case you need to give more. There's no, you can't give too much naloxone per se. It's not going to cause a lot of harm, although it could cause withdrawal. But if the difference is between withdrawal and not breathing, we choose the breathing. So there's a few doses there. It's not known for people to be allergic to it. And if you give naloxone to somebody who is not, you think it's a poisoning, but it's not, it's something else, it will have no adverse effects. So if you give it to somebody and it ends up they were having a heart attack or a stroke or an asthma attack or anything like that, it won't help anything, but it won't cause any harm. So this is a picture of the insert inside the naloxone kits that we distribute, that we get from AHS. So it's a wonderful fold out, and you can actually just unfold it while you're involved in responding to a poisoning, and it just very easily goes through what you need to do. I recommend when you get a kit that you familiarize yourself with this, because it's a fairly good way of being able to determine what you need to do. Okay, so I won't belabor it because we're going to show you how to give the naloxone, but it goes through the whole deal there, and it works really, really well. So what to do? So what we've already talked about, that we come upon a situation and we're just see somebody laying there slumped over and we're just not sure what's going on with them. So we're going to do a scene survey. Are they awake? Is there a change in skin color? Are they breathing? If any of those things are concerning, the skin color, breathing, or unconscious, we attempt to wake them up with painful stimuli and call 911. In kind of a pre-COVID world, the assumption would be that if you had CPR, first aid, knew what to do stuff, that if not breathing, you give 1 rescue breath every 5 seconds. I'm going to go into AHS's recommendations for how to respond in a pandemic in a minute, but we'll go through these too. So the rescue breaths every 5 seconds for a couple of minutes is around. There is a one-way valve mask in the kit that you should use if you've decided you're going to give rescue breaths. You're going to prepare the naloxone for injection, and then you're going to give it in either the upper outside of the thigh or the upper arm. So these 2 pictures show really exactly where you should go. Okay, the ideal muscle, the most ideal place to give it is in the thigh. It's a nice, good, meaty muscle with lots of blood flow, so it'll help get that naloxone to the brain real quick. It's also okay if you have to give it through pants or jeans or anything like that. Okay, that's the preference. But if someone's got a t-shirt on or a tank top and their arm's nice and available, go ahead and you can give it in that deltoid muscle, our shoulder muscle there. Okay, so you're going to give that naloxone, and then you're going to continue with the rescue breaths if you're comfortable. Here we say 3 to 5 minutes, AHS actually says 2. I apologize, I just noticed that. So if you give another round of breaths, so a minimum of 2 minutes, and the person hasn't waken up and the naloxone hasn't kicked in, go ahead and give another shot. People can wait up to 3 to 5 minutes, but most people cannot. It's too long. Just wait the 2 minutes and give another dose, okay? And you're going to do this as many times as you need it. Give the naloxone, 2 minutes of rescue breaths, reassess, okay? When they wake up, you need to explain what happened and talk about the risk of going down again. They can wake up feeling a little bit anxious, a little bit scared, sometimes short of breath, those kinds of things. So just keeping in mind that the person will need to be told, because it was an unintentional poisoning, we can assume that they actually don't know what happened. So give them some space and explain what happened. So the difference here is that we're living in this unprecedented times, as we've heard over and over again, and we're learning how we need to respond differently to different situations, how to work differently with people. And one of them is, how do you respond to an opioid poisoning, or really kind of any kind of respiratory emergency during the COVID-19 pandemic? So we know coronaviruses are spread commonly through respiratory droplets during exhalation and close contact with someone. So when you have COVID-19, or when the person you are assisting has COVID-19, it's considered to be at very high risk of transmission. Okay, the highest risk actually is the fact that if you were positive for coronavirus and you were blowing breaths into somebody that was experiencing opioid poisoning, that would be a high transmission. We have a one-way valve in the kits that can be used that will protect you if the person on the ground has COVID, but when you blow in, your resps go into that person. So it's just something to keep in mind. So AHS recommends that contact be reduced to decrease the spread of COVID-19. So anyone not directly involved in assisting in the response to the opioid poisoning should leave the room or immediate area, right? Like, just less people is best in a situation like that. So our responses very similar or could be almost the same during COVID. So we're going to call 911 and we're going to assess the risk of spreading infection. In an ideal world, you would wash or sanitize your hands if possible and don PPE. So those of us that have had to respond outside on the street or in the community know that the odds of having personal protective equipment on us or potentially having a sink to wash our hands is not super high, but if it is available, go ahead and use it. Many of us are carrying masks with us now, so go ahead and put those on if you can. So if PPE is not available, make sure that you put on the gloves provided in the kit, okay? That's at least some support, and then you'll administer the naloxone. If you choose to give rescue breaths, just use the one-way valve because it'll protect you, and again, but it won't protect the individual of the suspected poisoning. We're not recommending that you not give rescue breaths. If you are comfortable, you can, but it's not a requirement. And it's the same with pre-COVID. If you're not comfortable giving breaths, you don't give them, okay? But if you do not give breaths, you need to do the head tilt chin lift technique to maintain an open airway. So with somebody that is not breathing and has no muscle tone, their tongue can flop to the back of their throat, right? So that also impedes air. So it's just really important if you decide not to give the rescue breaths that you still maintain that open patent airway. So when the person is able to take breaths, that airway is open to get some air, okay? So you're gonna continue to monitor. If the person still is not responsive after 2 minutes, you're gonna give another dose of naloxone and continue with monitoring. So you're gonna do that every 10 minutes with the airway open, okay? So you'll do that until the person wakes up or EMS. So when respirations return, put the person in the recovery position if still unconscious. So often when people wake up, they just wake up, they sit up and they're kind of ready to roll. But sometimes if they've used a combination of drugs or a cocktail, that person might not wake up immediately even though they start to breathe. And that's why the recovery position is super important, to keep that airway open and just in case they throw up or something that we can keep them safe. So we need to make sure to thoroughly wash your hands after the response is done and ensure that the scene is cleaned after it has been cleared of garbage and EMS has taken away the person if they go with them. So when a person is awake, they may feel a lot of different emotions. Let them know what happened. Warn them about the risk of going down again when the naloxone wears off. So this is a risk. I haven't seen it a lot, but some of my coworkers have, that naloxone can kind of wear off in anywhere from 30 to 90 minutes. It's quite a long window. And in the event that there's a lot of opioid in the system or the person doesn't have a tolerance to it, there is the chance that a person could go down again on the opioid they've consumed earlier. So just warning people not to be alone, encouraging them to make sure they're around people to stay safe. Do either of you have anything to add to this, Audrey or me, with this part?
No, just like you said, Dallas, I think sometimes people can become disoriented, and I think it's always good to, and I think you mentioned it right during the last slide, but if you have to respond to an opioid poisoning, it's always a good idea to try to clear as many people away as possible. It can be really overwhelming when somebody actually comes out, of their overdose and wake up, and the last thing that anybody wants in any type of first aid emergency is having a whole bunch of people standing there staring at you. And so I think, yeah, just that sense of anxiousness and disorientation is often present. Sometimes people are not very happy because you have just, in essence, you've just ruined their high, even though they didn't necessarily intend to overdose. They can be upset. Sometimes the people will be crying. And I think it's just good to just be there to reassure them, let them know what happened, just like Dallas said. So, yeah.
The only other thing I would add too is adding on to ruining their high. They may go and get some more drugs and consume again and just again. And when that naloxone actually does wear off, it's gonna most likely cause another accidental overdose.
Mm-hmm. And also too, if you have to respond, or if you ever have had to respond, it's often a good idea to take some time to debrief with the other responders, or if there's somebody that you trust, because it can be a really stressful experience to respond to an opioid poisoning. And like we said, right, so if somebody, they wake up and they walk away, and it can kind of leave the responder feeling like kind of confused, or a little bit disheartened perhaps, because in essence you just saved somebody's life, and they might not necessarily be happy that they were just injected with naloxone. So that can create some difficult emotions for us also. And so just to be mindful of that, to definitely debrief. It can be a very highly stressful situation. So yeah.
Okay, so how does it work? How can you get naloxone? How do we get it to you? Those kinds of questions often come up. So how naloxone works is anybody can get a kit. We are trying to limit all barriers to people being able to have a kit in order to respond. So there's two kind of most common ways that you can get a kit or use our program. So one is self-referral. So you can access naloxone through our agency, which is Northreach, or any pharmacy in Grand Prairie, actually. We'll also be able to give them. It's a no questions asked kind of situation. We will ask you if you've been trained, and if not, if you'd like to be trained, but that's really it. Okay. And so then the other piece of our program is education, doing things like this, sitting down with you and offering you the opportunity to learn. We also, when the world gets a little bit back to normal and we can do sessions again, you can invite us, any of us, to come and speak to your a little recap. What we're looking at teaching people is how to pick up needles, or what to do if they need to call because they're not comfortable picking up a needle. So all you really need is some sort of hard plastic container. So Mr. Clean bottle will work, a water bottle, a shampoo bottle, or you can get actual sharps containers from us here at Northreach, again at no charge, to collect these. A pair of tongs and gloves is also helpful. So these are the what not to do things if you decide you're going to pick up a needle. You would never hold your sharps container while you put the needle in the container with your other hand. The reason for that is because there is a risk that you could drop that needle and poke yourself with the needle, and then you have to go and get screening done for Hep C and all those things. So set your container down, you're going to put the sharps in and keep your hands away from it, and then if you drop it, it just hits the ground. The other thing you would never do is pick up a needle and a lid and put them back together. This is an extremely high risk activity for getting a needle stick injury, and one of the ways that healthcare workers are most likely to stick themselves is trying to recap a needle. Okay, so those are just kind of the two things you don't want to do. So if you're not comfortable with picking up a needle, using your tongs and picking up the needle and putting it in a container, you can call us at Northreach. So our outreach number is there, 780-832-8548. That's the very best way to report a needle during this pandemic, because the outreach phone is on from morning till 10 o'clock at night, 7 days a week, so then we can respond to it. The other way is you can actually go onto our Facebook and post there, and the moderators for the Facebook will see it and send somebody out to get the needle. So many of us know that supporting individuals who use substances can be really overwhelming, and it's generally not something that we can manage or do on our own, especially if it's somebody we love or care for. We need to have outside resources assist a person who's struggling with any kind of substance use disorder. So there's many places in our community and in Alberta where you can at least get some help or some resources and know kind of where to go. We're one of them, being Northreach. There's also the Northern Addiction Center, Rising Above Society, the Youth Emergency Shelter, women's shelters in various communities throughout the north. So just reminding ourselves that we can at least access services to kind of find out the next best step in order to use self-care. So this is my plug for getting tested for STIs. Part of my job is testing people for sexually transmitted infections and bloodborne infections. We do this because it's so important for personal health and the health of the community. There's a syphilis outbreak in Alberta. We don't hear a lot about it, again because of stigma. It's extremely contagious. Basically, I tell people if they're having sex, they're at risk. So getting tested regularly is a really good plan. STIs are treatable and preventable, and so just getting tested will help. So you can go to your doctor, walk-in clinic, or call me at Northreach and we can set something up, okay? So the disease of addiction has no face. It doesn't discriminate. It's an equal opportunity destroyer. So the last thing we're going to do before we open this up to questions is I'm going to stop share and hopefully be able to try and demonstrate on my little camera how to draw up naloxone, just so you have a little bit of an idea of how this all works. So we only have the camera on our computer right now, so we're going to see what we can manage here. I have to stop sharing. You need to put your camera on. Okay, so hi everyone, it's me again. So what we're going to try and do here is show you how to administer naloxone to this little bouncy ball. We use this guy as our kind of our little demo person, the person that's experiencing an opioid poisoning. Okay, so what we're going to do is we're going to try and see if we can get this to work. So I've done my scene survey. I figured out that he's not breathing. Ebony, do you want to just look? So we've seen that he's not breathing. He's blue around the lips. He's not responding to pain when we do a sternal rub. And so what we're going to do is we're going to prepare to give naloxone. So the very first thing we're going to do, and like I said, was super important all the time, especially during these times, if we don't have PPE, is to don the gloves that are in the kit. So we're going to put these on. They're not the worst, but they're not the best either. So we're just going to tuck these on us. And then we're going to prepare to give the naloxone. So our naloxone is in a syringe or a syringe package like this. And so you're just going to take the top and open it up. Okay. And you're going to get the syringe out. So what I like to do before I do anything else is I like to loosen the barrel of this syringe to make it easier to drop the naloxone. Okay. And so then what you're going to do is this naloxone has a little white cap on the top in your kit. So what you need to do is flip it off. Okay. And then you're going to be able to pull the fluid out of your vial. So taking your time, because the best way to waste time is to move too fast, because you will stumble, you will drop things. So just take a deep breath, tell yourself you've seen how to do this, you know how to do it, and just slow down a bit. So you'll take the lid off, and you're going to the most stable way to do it is to set the vial on a steady surface and press your needle in. Okay, I'm going to show you one other way to do it, because often in this world, what happens is that we're actually outside or on a dirty floor or something where we might not be able to find a clean surface to set our vial. So the other way to do it is to actually hold it upside down. Sorry, this video. And instead of jamming the needle into the vial, you're going to push the vial down onto the needle. It's just a little bit more stable. Okay, so now what you have to do is you have to pull back until you can just see the needle past the silver part on the vial, because the needle is longer than the fluid in here. So in order to get all the fluid, you need to pull the needle back until it's just barely in the vial. And then you're going to pull all the fluid back, and you're going to get about 1 ml. That's how much is in there, and that's the full dose. Okay. So then what you're going to do is you're going to push the air out until it's just below the spring, and then give the plunger a little tiny turn to make the fluid come out the top. Okay, so then you know it's primed. So then what you're going to do is you're going to take that nice meaty muscle on your thigh, and you're going to just make sure that you are kind of on the outside portion of the upper thigh, and you're going to hold your syringe like a dart. And the reason I'm saying to hold it like that is because it's the best way to give like a very smooth, quick injection. And you're just going to dart it in. You're really going to give it almost like people that have given epi. It's like that. Just go for it. Okay. Because it's that you don't want to have your needle bounce off the jeans or whatever. So you're going to inject it, and then you're going to, with slow, steady pressure, push until all the fluid's in. Now, you're going to push on that plunger until you feel and hear a click. The reason for that is that you want to make sure that you hear the click, because that means that the needle actually popped back into the syringe. So sorry, I'll just stop this bit. So as you can see, I no longer have a needle here. You don't have to worry, the needle actually sprung back into the barrel. So now you can throw it to the side and continue to assess your client and not worry about getting a needle stick. Okay, so then what you're going to do is you'll take your 2 minutes to either give rescue breaths or keep that airway open before you decide to give another dose. Okay, so that's it for the formal part of this. I know this demonstration wasn't super ideal, and once restrictions lift a bit more, I'd be happy to show any of you here in the office, or even come to you, because I can drive around the community and in the north area to demonstrate. Okay, so I'm going to go back to my computer. We'll turn on our cameras, and we'll see if you guys have any questions. Does anybody have any questions? We'd love, you don't even have to type them. You can put your camera on and ask us or talk to us. But was there any questions or concerns about any of the content you heard today?
And everybody else is welcome if you want to turn on your cameras now. And everybody should be unmuted.
You can also type your question if you don't want to talk.
Okay, so we have a couple of questions. Okay. Oh, no, just some feedback. Thank you, everybody.
So where's the sound? While people think about if they have a question, there's also going to be a survey coming to your email for you to just provide a survey for us, because our funders and the government need the surveys as far as how things went and how you learned and how this was for you. And they are anonymous, so just so you know about that. The other thing is this will be posted to our Instagram and Facebook so that people can watch it again, or people that didn't register can also access it.
Do we have a speaker on? No? Okay, I'll put my speakers on.
Yes, Chris, you can get a copy of this recording. You sure can. We'll be able to make it available on Facebook and on the Northreach website, as well as Instagram. So yeah, that's great. So I won't necessarily send you a copy, but you'll be able to access it as many times as you want through social media or on the Northreach website.
Okay, the speakers are coming through here.
So we can pretend.
Okay, so Chris is asking, is there any consideration for injection sites for naloxone if it's a small child?
That's a really good question. So generally speaking, it's not something I've actually ever seen, having to give naloxone to a small child. So if you're talking like a very young kid, so I'm assuming like an accidental overdose or something like that, like if someone got into grandma's morphine or something, is that what you're thinking, Chris?
Yeah, I'm thinking a kid that accidentally took something from home, and they show up at school and they have those clear signs, but it could easily be a 5-year-old that took something that they shouldn't have from their parents' cupboard.
Chris, hang on.
I was getting feedback, so.
Can you restate that?
Sure. You know, the thought was if I had a child that had accidental exposure because they took something from home, and then that exposure, and then we have the crisis on site. I was just wondering, you know, sometimes it's hard to find deep muscle tissue on a small child. So would you still recommend we aim for the leg, or is there a different part of the body that we should aim for with a small child? Or is there a consideration, maybe 1 cc is too much?
So that's a really good question. I don't actually have like what I would call guidelines for small children for this. The thigh would still probably be the meatiest part of the body if it had to be done. I would really be using caution. Like, I mean, that needle on there is made to inject into an adult. That being said, we do have some really tiny people. Some of our little ladies have very little to them, and we still administer it. I don't think there's a change in dose, but I've honestly never given naloxone to a child. So it's a really good question. I'd like to find the answer and get back to you on that. I'll email you or something. Yeah. So I think we'll just give it a couple more minutes, and if there aren't any other questions, we will let you go. We really appreciate you joining us. This is our first kick at this, and so we just appreciate your grace with sound issues and with possibly us talking too fast, and some of the things we're just still working on navigating this whole new world of trying to touch base and connect as humans with people through the screen. I'm sure you've all experienced that a lot as well. The fact that you're here says that you've probably Zoomed before. Okay, yes, Sophia, I'll probably just send the answer out to everybody, and then that way we can, yeah, that way we know. It doesn't so far seem to be like opioid poisonings so far does not seem to be really a youth issue yet. It's not hugely on the radars. I think, generally speaking, for a lot of children, again, I think it would be a real, like an accident getting into somebody's pills or those kinds of things. But the question is valid, and if you got the kit, should you use it on kids? So I'm gonna find out.
Dallas, do you maybe want to just talk about if they have to use a kit?
Oh yeah, sorry. This is a good thing to address. So if you do use your kit, there's a couple of things that we do ask you do if you feel comfortable. So one of them is that even if you've used one vial out of a kit, that kit is considered used, and you need to come in and trade it in for a new one. The other thing that we would really appreciate is that there's a small form that we fill out about overdoses, and on that form, it's like completely anonymous. It just talks about the approximate age of the person that was responded to, the town that the poisoning happened in, how many shots of naloxone were given, if you called EMS. Very basic questions that AHS gathers to see how successful how successful the naloxone program is. So getting those sheets filled out is a key component of the whole harm reduction piece of naloxone. So bringing it in, getting a new kit from us, and then just quickly filling out a little anonymous form is super helpful. The other thing is those kits do expire, and so right on the back of the kit is the expiry. So when it expires, again, any pharmacy, us, anywhere, just trade it in and get a new one. And with that is the fact that if you get the kit from us and you're somewhere else, you can certainly trade it in at a different location that gives kits. It's not like, oh, I got this from Northreach, so I have to trade it in Northreach. There should be no barriers to naloxone from any distribution place in the province. And that's really important. And if there is, that needs to be, we need to figure that out, because there should not be any barriers to naloxone. So yeah, yes, the kit expires. Sorry, yeah. They're usually about a couple of years, right? So they usually last about 18 months to 2 years after we get them in before they expire. So it's quite a good amount of time they last.
And I think the same thing as the considerations to make for whether it has been exposed to extreme temperatures. If you needed to respond and all you had was a kit that was expired, we'd say still go ahead and try and use it, right? I mean, the efficacy of it might be reduced. However, it's still a good idea to use it. So
yeah, and the research shows that an expired kit will work. They've done the things. They've done it with frozen and expired. I don't think they've done them with hot ones. But so yeah, if there's no other questions, I think Audrey and Ebony and I will just sit here until you guys have logged off, just in case somebody ends up having a question. So we'll just hang out here, and you guys are welcome to go. And like I said, I'll send that survey out, and if you have time and feel like it, you could fill it out. And yeah, we're thankful. Thank you for joining us. Thank you for being our test team, really, for our very first webinar. So thank you, everybody.
yes, thank you everyone for your participation. And hopefully at some point in time, you'll be able to get some hands-on practice.
Sophia has a question.
Oh, go for it, Sophia. Did you want to ask it or type it?
Sure, I can ask it, sorry.
Okay.
I just want to talk a little bit about the, if there's a Good Samaritan kind of protection thing, because someone might be afraid of calling for help, right? And so I wonder if you can touch on that and see what, I mean, I wouldn't, but I know some other people would be afraid of calling. So if we were going to educate other people about drug and overdose and stuff, just talk about what's the guidelines on this Good Samaritan rule kind of thing, if you can talk about that.
Audrey, did you want to take that one, or Ebony? Good Samaritan?
From what I understand, so they did do some changes to like federal laws a couple of years ago. And so with that being said, the Good Samaritan Act is in place so that if somebody was to call, they're not going to be arrested for possession, for instance, right? There's a couple of issues with it though, is that if, say, there was somebody who had been, released and they have like probation orders or parole orders and they are, in violation of that, and say that an officer showed up and they happen to, perhaps know that person, it's not going to protect anybody who might be in violation of a pre-existing order, right? It's basically meant to ensure that people are going to call EMS, right? So it can get kind of tricky, right? Because I think there is a lot of fear out there. However, I mean, if like you said, if you or I were to call and say we were at a party or something like that, and the EMS and police show up and there's illicit substances there, as long as we're not in violation of anything, then we are protected. So I hope that answers your question. There is a lot of information also online about that. So let me see.
Thank you.
He's asking, is there protection for the individual distributing the naloxone in a situation of a purposeful overdose?
Yes, because there's no way to know if an overdose or an opioid poisoning is purposeful. That would be a very difficult thing to gauge. And so what we tell people is it's that life or limb kind of situation. So there's very few people that do not want to be brought back from the brinks of death. And it is our responsibility to respond to a lack of respirations and to a lack of life-giving vital signs. So I hear what you're saying, but that would be a quite an unlikely event given the statistics we have on opioid poisonings. The overwhelming majority, and when I say majority, I mean essentially all. There'd be very few that were with the intent to end life. Mm-hmm. I don't know if that helps, but go ahead.
You would be covered basically by acting in good faith rule, right? By preventing that death.
Great question.
Mm-hmm.
Okay, we're going to stop the recording, but you don't have to stop asking questions. We're just going to pause this because it's hard for people.